Good afternoon. This is great to be here. This is my first visit.
Welcome.
It won't, hopefully, it's the beginning of something, and I'm very interested in seeing who I can collaborate with coming out of this. I'm a physician trained in surgery, left my residency to start a software company, and we were the first EHR at Kaiser Permanente, California. We lost out to Kaiser, and then we sold the company to Cerner. And then I worked on physician adoption with a number of companies on market validation and work in driving physician adoption with SureScripts, with Athena Health's first EHR. I went back into the EHR business with MedSphere, which was an open source EHR that came out of the Vista system from the VA. Thinking that could drive adoption in 2007, 2008. Meaningful Views came along, and we all know, we're all quite familiar with how that turned into a spec for a very complicated EHR. What I saw during that period, then I went from there back to Athena to help them with their they went after small hospitals before they got kind of reorganized, but I got spend a lot of time with critical access hospitals and seeing primary care in a hospital setting with one doctor, 3 beds, and a helicopter that would fly in. And but the thing that I came out of all that, and I saw doctors getting increasingly burnt out, and I started working with the Academy of Family Physicians in 2019, and we created what was called the AA, the American College of Family Physicians Innovation Labs. And we looked at innovations that could actually give physicians hope and that showed promise and actually affecting. So we were biased towards innovations that had some promise and had some proven early success, and trying to figure out how we could show that there was opportunity with technology and payment reform to actually improve their situation, because I think there's a real gap in, there's a lot of pessimism. As you know, that there's studies that show 50% burnout. There's studies that show 57% only 57% would do it again. So I don't know how we expect people to go into primary care when 40% of them are saying they wouldn't do it again. So what we do at Phyx is a spin out of the labs at the Academy to focus more broadly on and to work more broadly with companies, innovators, organizations beyond just family medicine, and to evaluate. We're not actually doing the innovations, but we're evaluating their impact on the primary care experience. And I'll explain that. There's going to be a bunch of numbers. So don't get, it's going to, they tell you not to put so many numbers on slides, but anyway. So the main thing here is that burnout is, there's administrative burden, but at the heart of it, professional satisfaction has, purpose, mastery, and autonomy. And if you want to undermine that, you take away agency, you take away a sense of purpose, you undermine decision making. You put people on it. You make them. You design an EHR where the physician is the cog that runs the user interface, and then you put them on a treadmill or a hamster wheel, and that's what's happened with fee-for-service. And you can't have a primary care relationship in 10 minutes, 12 minutes. You need. And there was a leader at the Academy that. A resident got up last year and said, what should I do in my contracting with, this is a family medicine resident coming out, what should I do in my contracting? He said, demand no more than 2 patients an hour. He said, you cannot have a primary care relationship in 15 minutes or less. You just can't maintain it, or 30 visits in a day. So you just can't know your patients. And most of the people that went into family medicine, I believe, have done it because they want some relationships. So there's going to be a conflict there. So what we see is that there is an opportunity with giving physicians a vision and giving them the data. They want to know stories, they want to know anecdotes, they want to see both the objective and the subjective proof that innovations could work for them. This gets back to these discussions of adoption. They have to see it, they have to hear from a physician like them in a practice like theirs that it will work, and that it's being done by not just the innovators, but someone like them. So there finally, we hear this now, finally there are some technologies, and AI is at the forefront of that, and I'll show you the data that we've seen on that, and payment reform, and you've heard already about it today in a couple of value-based direct primary care. So we have a map, and the imperatives are relieve burnout. We think it's, if the physician is our patient, these are the signs and symptoms that we have here. We have burnout, we have overtaxed time and burden, they can't afford to practice in their setting, they feel like they're on a treadmill, and their scope of practice has decreased. Here's some innovations within each of these categories. Assistance. There's a lot of AI out there that's going to be applied to healthcare. There's a type of it that's aimed at assisting the point of service and assisting the clinic, the physicians and the team in taking care of the patient and helping the patient also. And so we see a number of assistant applications. Then there's payment reform, there's direct primary care, and within that, there's innovations and systems that need to be put in place to support that, and then value-based care. You see at the bottom. And then, this is what we want to look at. This is what we do, which is we're not looking at, we're looking at what are the metrics that actually point to an improvement in the primary care experience. So we have, the main one that we use is the vital signs, which is the 5-point burnout scale inventory, patient satisfaction on the 5-point scale, visit time, what's your typical visit time scheduled, rating your patient care time from ample to inadequate, after hours time, and burden-specific metrics, which are specific to whatever burden we're looking at. And then the primary care, we're looking at the 4 C's, and you'll hear about the primary care, the patient-centered or person-centered primary care measure, and Dr. Etz will be talking about that in detail. But that is the one that we have in hand to address the 4 C's. And we're looking at other proxies for the 4 C's, which is first contact with access, comprehensive continuity, and coordination. And then the real key is total cost of care. The last, the talk before the last one was very much focused on getting to those hardcore numbers, which is what we definitely need. We need transparency around what it's actually costing. And who knows, right? So just that transparency and understanding that gives us some, and you can see the other topics under that one, but that's a big bucket. But we're really focusing right now because we can go to the doctor and the patient and get these first 2. So if we look at, this is a study, if you haven't looked at it, it came out earlier this year, and there was a study from 2017 called Tethered to an EHR, and it's from the University of Wisconsin in Milwaukee. And this is more tethered that came out in 2024, and it shows that for an 8-hour day, there's an accumulative 5.3 hours of EHR time, and that 2 hours of it was in documentation, 1 in review, chart review, 1 in orders, and the big one that grew was inbox. Because after COVID, this one exploded because patient portal messages became mandatory to respond to within 24 hours. And so the report does go deep into the inbox one, but they showed that it was more tethered than 2017. So the 2 AI assistants that we looked at were Suki. There's a few leading solutions. In general, they have similar types of technologies. I'll just say that up front. Suki we worked with, and then we worked with a company called Navina on chart review and on coding. And they work on coding for value-based around using the chart review. If you're not familiar with the ambient, you go in the room, you put your phone down, and it listens to the visit, and it creates a note. And it has gone, since I've been watching it over the last year and a half, it's gone from being kind of okay to being unbelievably good. You can have a conversation in the middle of it about bowling or about traveling to Europe, and it'll ignore the whole thing. You may have mentioned that you flew to Africa, and it will pick that one up because you might have some viral disease. So it's gotten really, really good. And it's like having a chief resident or someone who's worked with you sitting in the room with you, and it will capture and put it into a very professional report. And it's blowing up in the marketplaces, but basically becoming an essential tool very quickly. The chart review goes across all available information and collects and creates a problem-oriented summary, and then actually will apply AI for recommendations around suspected conditions, around diagnoses that you may not know about. And so it saves the doc a ton of time in terms of prepping for the visit, supports the visit itself, and supports the HCC coding, which is complex, and that you have to have in place so that you get your capitation scores and RAF scoring correctly done. So going back to the Venn diagram, this is where those two circles come together, the payment reform and the AI. Now, if we look at the Suki, this is a ongoing study. Right now we're up to 95, but this is when it was at 82. This is before and after the use of the tool. The burnout score went down. We had burnout go down 23%. Satisfaction went up 21%. Visit length went down, which is not necessarily good from what I just said earlier. Care waiting time went up. After hours, 45% down. And you can see the note time, 42% down. Pretty impactful. And that's kind of what I'm hearing, in the marketplace, that this is kind of the numbers you're seeing. But this is on primary care specific across the country, 82 data points. This is the chart review, which is a little less impactful. And I'll kind of get to that because when we get to we're going to talk about value-based in a minute. Value-based actually increases the demand on chart review and on coding. And so the burden goes up before you start doing your chart review. So this is down 12%, satisfaction up 5%, visit length down, care up a little bit, after hours slightly, prep time 8%.
I have a quick question.
Yep.
Do you have a sense, I feel like the world of EHRs, there are two pathways. One would be a more open architecture where multiple of these kinds of products are competing and you can integrate any of them with your EHR. And then some of the EHRs are going to try and lock it down and say,
Yes.
that we only sell our product with this product. What's going to happen?
In working with these companies, we're running into just a handful of EHRs. Athena, eClinicalWorks, Epic, Elation. I can tell you long stories about each one of them. But Epic is not as friendly to interoperability. They can do it all themselves. They've got the worst. They've got all the studies that are coming out of academic centers that are using Epic, and everybody's getting trained on Epic. A lot of these docs that you're seeing here that are in smaller practices are not on Epic. They're on Athena, which is much friendlier to a primary care provider, and Elation, which is dedicated to primary care. So there's a huge difference. And I think of those two that I just mentioned as innovation platforms. whereas Epic is a monolithic, and it's built to run a hospital or a small city. It's not built to run a practice. So now if we look at sustainable payment models, this is just for illustration. Value-based, if we ask these practices that and this is a smaller set at this point that I'm reporting on, an N of like 10, this next study is an N of 10. But you ask them, what are your arrangements? And it's like this 5-minute conversation where there's a lot of vague answers and it's not clear. And then they're doing it for Medicare and with some other payers, maybe. And they're halfway, so it's complex. And it gets back to the polar bear and the seals, or the frog and the frog and the scorpion, right? The scorpion says to the frog, "Can you take me across?" And he goes, "I'm afraid you're going to sting me." And then he convinces him, and he takes him across, and he stings him. So it's in their nature to make things complex and to make it hard for that. They want to say no to the payment. Direct primary care is a much simpler story. I do totally agree with previous comments about standing alone on just retainer is not the key, but these employers are going to start asking for a minimum data set, and they're going to start competing on quality and cost. And the key is not making it complex. And I think there's a real opportunity there. But that has not happened yet, and there's a study that Milliman did previously that they're with the American Society of Actuarials, and they're doing another study with, I think, 8 employers, self-insured employers, and on a big N, and on total cost of care. And it's pretty dramatic, previous findings, and if they can prove that, then a lot of employers may be more interested in that model. The idea of comprehensive catastrophic care, catastrophic coverage by insurance, and then retainer-based primary care. If we look at this study, which was an N of 10, we interviewed, this was not a survey, this was interviews, and we interviewed them on burnout scale. And you can see there was 2 groups that ended up with, one did not have burnout afterwards, one group had burnout afterwards. They both had the same burnout going in, but one went down. This was 5 and 5, just by chance. If we looked at the difference in those 2 groups, the staff ratio for the burnout group was 2.7 staff to physician. And the other group had twice as many. So there's a little chicken and the egg going on here. Because yes?
What was the number of participants?
This was 10, 5 and 5. This was direct interviews with physician leaders of value-based, organizations doing value-based.
And
yes?
was this controlled for panel size?
Excuse me?
Was it controlled for panel size?
Well, you're going to see the panel size in a minute.
Okay.
Yeah.
Sorry, one quick clarification. If I'm reading this correctly, the folks who experience less burnout afterwards were the folks who were more heavily staffed. Am I reading that correctly?
Yeah. So this is, 6 to 1, under 3 to 1. And then if you look at, this is a little chicken and the egg here, right? So we're seeing this after they've adopted, or they're trying to adopt value-based care. And this is the ratio of value-based to fee-for-service. And you can see that the burnout group had more fee-for-service, like 60-40, and the group had made the leap to 60 plus, over 60 plus value-based. And there is some data in the literature pointing at the number 60%. People talk, there's an article that just recently came out that says, good on paper. You know, is value-based going to be successful? It looks good on paper, but in practice, you have to jump through major hoops to make it happen. But if you can, it could work. Now, they never get rid of fee-for-service. There's always this like, oh yeah, you're still going to do fee-for-service. So you hear this story of a foot in 2 canoes, or a foot in 5 canoes. You have that image of, and you're also still on the, one of those, you're on a hamster wheel, right? So it's like, I don't know, and then you still have to take care of diabetes and adopt the new clinical guideline that just came out. I don't, you know, these doctors they're special people, but we're asking a lot. So now if we looked at the vital signs, this is the small ratio, right? 22.7/1. Their burnout went up 24%. Satisfaction, for some reason, went up. Don't know. I got to go back and then the visit length got a little bit better. The care time went down, and their panel size actually went up. And then the larger group, 6-to-1, their burnout went down 36%. These numbers you see are pretty impactful, right? Down 36%, up 31. Visit length went up from. There's a big difference in perceived anxiety if you move from 15 minutes to 10. It takes the power of 5 minutes is huge. 15 to 20 is a big deal. That's in my listening to these guys, and then and ladies, and the care time went up 61%. Panel size went down. So there's a lot more work to be done here. We're working on an ongoing study on this. Now, direct primary care. This is an N of 12 right now. It's ongoing. This is work we're doing with HINT. And I'm going to show you some work we did on the PCM to follow this. But, you know, burnout just disappears. And then satisfaction goes through the roof. Visit time doubled. Care time doubled. I mean, the care perception after hours becomes, basically, burnout goes away and there's still stresses. You have to maintain your membership, you have to build your practice, but the creativity also goes up. The scope of practice and so forth. There's other slides I have around additional services that I'm not showing today. But they add, improved access, mental health, they feel much more, they're providing better, more time on mental health, more time on procedures, less referrals. But you see the panel size goes way down because that's what they want. They don't want, and they're providing, in direct primary care, they're providing full access. You can contact them, and you don't have to get your care just by visits. You can get your care by text or by email or by virtual. This is the patient-centered primary care measure. Now, if you're not familiar with it, someone's going to explain it to you later this afternoon. But there's 11 questions that they cover access, they cover coordination, they cover comprehensiveness, they cover continuity, and there's a little bit of a Venn diagram there. And this is the study. This is one of the study that it's comparing it against. But you can see it's all 3-point, it's on a 4-point scale, and you can see it goes from 3.3 to 3.9, and an average of 3.6. I used Dr. Etz's study. This is not a benchmark, and she can speak to that. There's no benchmark right now for fee-for-service, let's say, but we're trying to get one. But you can just see that my doctor stands up for me. That's like advocacy, right? Knowledge of my family, knowledge of my community. So that's a tool that we look to use more. This is HINT did this they have 1,200 respondents right now, but they're looking to use this as a tool across their whole platform. And then we did these questions. I just changed this without any permission to aim it at the physician. And we asked these 12 physicians, and they gave us those scores. And they couldn't help in making comments of comparing it to their previous situations. So you can see that we're looking to make this data-driven. Behind all this, the idea is also to have kind of case studies, which we call bright spots, that are the stories that you can add to this data to help drive adoption. We want doctors to hear from physicians like them in practices like theirs. That is